this study that we randomized patients to two different approaches. So one was the typical ARDSNet, and the other was PEEP titration based on EIT, which is not going to give us a PEEP titration very different from the best compliance. There are some situations in which they are clearly different, but not all. Most of the cases, they are going to coincide. But this is something just to follow up in the discussion that you see when you compare, this is the low PEEP FiO2 table, PEEP. And so every single patient, before randomization, every single patient was titrated according to ARDSNet and also according to the EIT. But then the patients were randomized, and then they follow one approach or the other. But it's interesting to see that, so if you are in the ARDSNet and then you are going to have your PEEP titration, sometimes you increase PEEP, but sometimes you have to decrease your PEEP level, as we are discussing. And then, so not necessarily is a high PEEP. In fact, the average here is just 1 centimeter above than this, the average. So it's about the same. But this is something really interesting. If you are using EIT, you come with a higher PEEP for obese. It's quite obvious because they have much less overdistension, and then the crossing point is going to show you a better PEEP. And this is the patients before randomization, so driving pressure was the same in both groups, but then 24 hours later, there was a difference in 4 centimeters of water that was sustained along the time. So compliance got better and driving pressure got 4 centimeters less. So this is something that now we are changing a little bit our philosophy, which is we titrated PEEP every 2 days in the patients, and to our surprise, the need for PEEP doesn't decrease along the days. It's just 2 centimeters of water. This is this small drop here. So it looks like that the need for PEEP is anatomical, it's not from the disease. And another clue that this is true is that in surgical patients that have normal lungs, the need of PEEP was precisely the same as COVID patients, just 2 centimeters in average less. So most of the PEEP that you need is just because you are lying down, supine, and you have anatomical chest wall, belly, fatness, and everything. So it's not coming from the disease. And this is something that what we are discussing do. So this is the drop in driving pressure after randomization if you follow this PEEP titration. So in every single patient, you decrease a little bit your driving pressure because you are trying to find the sweet spot for every patient. But if the patient is a recruiter, you have a much larger drop. But still, you're not causing harm. If you're using the ARDSNet, this is here, and this is a little bit lower here. So then I think just to stress the point that the recruitability is very important if you're using the ARDSNet, because or some convention because you really are going to cause an increase in driving pressure for the non-recruiters, and the recruiters, they can go with a higher PEEP without too much trouble. So okay, so just this study was a meta-analysis, not this one that you presented here, but it's another meta-analysis. Because, you know, meta-analysis, they are very tricky because pretty much depending on your selection criteria, you put a lot of weight in a few studies and you ignore many of them, conveniently or not, or depending on And then, for instance, but this other meta-analysis after the publication of the ARCH trial is still showing that recruitment maneuver and high PEEP is favorable. You see, so I think maybe I think it's important for you when you're presenting the recruitment maneuver too and things like this, that I think if you look at the literature very carefully, it's still an equipoise. You cannot say that the ARCH trial changed everything. It's a kind of biased approach because you're putting too much emphasis in one single study that was done in a very peculiar, right? So, and then, and also, there is, let me just show you one more thing because it came to my mind. Yes. Let's just summarize what we have as mechanical ventilation trials. And it's interesting because not all these studies are considering the meta-analysis. So 95 we published a physiological study, 98 it was the New England. Then we had these 3 studies comparing high versus low tidal volume, right? Then we have the ARDSNet. Then we have the alveolar that was testing high versus low PEEP FiO2 table. Then we have all these studies here that were testing also high versus low PEEP. And then finally we had these 3 other studies, ARCH, EPIVENT, and FARLAP, and this LIVE, which was a kind of French study from Jean-Jacques Rouby, was testing the personalized approach. So they are trying to find, okay, diffuse ARDS, they use a higher PEEP. It's interesting to think about like this, that here we proposed a multiplicity of mechanisms. Then all these trials were testing low tidal volume. This was a big success. So this story was a big success. Although here we said, oh, protective strategy is good. These studies, they all said protective strategy increases mortality. I know because in our hospital we started to use high tidal volume again. And then the ARDSNet said, okay, now you decrease it. But from this point on, only confusion, right? So, but it's interesting because I think the question is not set yet. I think we should not say that the ARCH trial eliminated all other things. It's just, and I'm not going to talk about the ARCH, but I would like to just show some. Oh, look at this. Just to understand how mechanical ventilation is confused. This is from 95 to year 2000. So our study was showing improved mortality when reducing tidal volume. But then look at all those studies. They were showing opposite results, right? and finally, then the ARDSNet came, right? So it's just to say. So I think we forgot about this. But you know, mechanical ventilation is very difficult because what you plan to do is not what happened exactly in the trial. So I think we have to keep some criticism about. But what I would like to show you is, this is the study from Bob that was also positive. But what I would like to show you, let me just jump to something here, is the following. However, what I call however, is that, okay, this story about the high PEEP studies never produced a positive study. However, this study was performed in our institution, and no one, it's interesting that very few people quote this paper, but we have 300 patients. We randomized to a high PEEP and low PEEP strategy after is the post-operative cardiac patients. So it's not precisely ARDS, but they have a very low PF ratio. They have a PF ratios around 200 or less. And then they stay in the ICU typically under mechanical ventilation for 24, 48 hours. And we use the recruitment maneuver going up to 45. For minutes? This was, I don't remember if it was 2 minutes. You think so? Maybe. And then so typically these patients, they had this kind of, let's say, EIT image, so you don't see any dorsal ventilation. And then after the maneuver, you have this. And then we had a positive result because we decreased pulmonary complications significantly, and we decreased the length of stay. So it was a moderate recruitment maneuver. I would say in terms of pressure is moderate, but in terms of time, it was 2 minutes. Very good assessment to not have hemodynamic problems. You see, we always try to have the blood pressure at above 80 to start. You have a drop, but then you recover. You never reach below 60. This is the control group. Experimental studies, there are abundance of situations in which you show that if you compare open lung versus ARDSNet, there is a big difference, right? So no question about this. We have also some results on cytokines. We have some human studies showing that you have less inflammation. But what I would like to show, let me just jump this. One second, I will come there. Is the following, that this study came from, this is the results of the new EPIVENT study. So the study that used esophageal pressure to titrate PEEP, trying to reach slightly positive transpulmonary pressure. It's interesting that this approach gives you exactly the same PEEP as EIT. So every time you have the crossing point, we realize that the crossing point between collapse and overdistension, we have a transpulmonary pressure of +2, between 0 and +2. This study was negative, but once they did a post hoc analysis comparing the patients in which they were on the target in terms of transpulmonary pressure, they had a positive result. I'm just trying to say that the literature, if you look carefully, there are signals that there is still some room for improvement. I think the problem is that we are kind of doing this kind of, let's say, very naive strategies that, oh, let's increase PEEP by a new table, or let's increase the PEEP like even the Express study. Oh, let's increase PEEP until reaching a plateau pressure of 28. So some strategies that they don't have any good rationale. So I'm just trying to defend the idea that we should keep the recruitment maneuver in the ventilator. Okay. I think because, if you look at carefully, I think there is still some issues that we have to resolve. Okay. Now let's talk about the okay. So the idea of this recruitment maneuver is to detect this type of animal or this type of patient. So you increase PEEP and then has a beautiful response. And as compared with this animal or this patient that was already recruited and then so maybe has a viral pneumonia and then it's not going to gain anything, right? So this is what we would like to have. I would like just to make a few, let's say, a brief review on the methods here. Costa method is the EIT method that we use. So we titrate PEEP and we try to find the crossing point between collapse and overdistension. Extended Costa method is a kind of analysis that we do that we can use in the long term. For instance, let's suppose that I did a PEEP titration. And let's suppose that I do many maneuvers with the patient. I can still calculate, let's say 6 hours later, I can still calculate how much collapse and overdistension this patient has with EIT. And this is what I call extended Costa approach. So we estimate collapse and overdistension not only during the titration, but for a long period of time. Then I would like to talk a little bit about this recruitment to inflation ratio, because maybe lots of people, they are going to ask you, oh, how your method compares with this method proposed by Laurent Brochard. Because people in Toronto, they are suggesting this method. And then our method, that is our tool, which is kind of compliance gain, right, that we built in the ventilator. And by the way, this was an idea from Bob, right? So Bob should be here, but this was an idea, but you're going to see that this method has a very good physiological background. So this is the EIT method. I think just to review, so we do decremental PEEP trial, and instead of just assessing the compliance, like people typically do in the ventilator, we try to find this crossing point between collapse and overdistension, right? The blue is overdistension, and you see it does not coincide with the best compliance always. Why this? I think for 2 or 3 reasons, but one of them is that the EIT is here, and so there is very little representation of the lung that is let's say the apical lung regions. So we are taking just the big slice, thick slice, but I like this because you are taking the most overdistended lung, which is this, and the most collapsed ones. So you are taking the extremes of the lung. And then this compliance curve is more or less, I'm taking the average of the whole lung. So sometimes they do not coincide precisely. And I think EIT is very sensitive to overdistension. So typically, this crossing point is a little bit below the maximum compliance. Okay, but something that is very beautiful to see. What happens if my patient is obese? You are going to see. First of all, we have done lots of validation studies comparing CT versus EIT, and they match very well. Lots of studies, so you really can believe in these results in terms of % of lung mass that is collapsed. Lots of studies. And in this study that we did to understand the benefit of this recruitment tool in the Nihon Coda ventilation, we again tested how much the EIT was matching with CT, just to be sure that we can publish this study in a good journal. And again, we had perfect match between CT and EIT. This is the estimation based on EIT, and you see that it's matching very well the CT results. In fact, with a very good correlation between both methods. These are these peaks that we studied. So the collapse estimated by CT in the x-axis and estimated by EIT. So why we did this? Because this we did for 5 animals, and then but the whole study we performed in I think 12 animals. So, but then we can guarantee that what we are presenting as the EIT results represent really what you would see by CT. again. Okay. What happens if I have an obese patient? Just to understand a little bit the philosophy of the Costa method and the recruitability assessment. It's interesting that we can reproduce obese patients in pigs by doing this. We just put some weight on the belly. I have exactly the same result as an obese patient. And then this curve shifts to this curve. I like this very much because look at what happened. You see there is a perfect shift. Compliance gets the same maximum value. It's just because you shift everything to higher PEEP levels, but you see you can use 14 of PEEP now with very little overdistension. This is the beauty of this method, that it's capturing this. And if I had an esophageal balloon, I would capture precisely this. I would capture that the pleural pressures increased by precisely the same amount. So, and I like these results because this make me very confident that we can really use high PEEP in obese patients. You are not causing any overdistension, and you are just you are keeping transpulmonary pressures in a very similar levels. Also, the shift is also observed when doing Trendelenburg. I like this. Look, this is the crossing point here is 11. Just by doing this, the crossing point is 16. Because now it's not an obese patient, but all the belly is on top of the lung. So same results, esophageal pressures are going to increase by the same amount. So then when I see this in EIT, I know that we are doing precisely this. We are trying to keep the transpulmonary pressure at the minimum point that I don't have too much collapse and not much overdistension. And then for these patients, because one of the ideas, and this is something that we can think for the future, Laurent Brochard started to, he's doing this kind of plug meetings. Maybe you are aware about it. The plug meetings is a kind of very nice initiative in which they are trying to do multi-center physiological studies, which I like very much because you are collecting data not to prove that a randomized treatment is better than other, but to collect information in a multi-center fashion. And for instance, I participated in this study with the same patients, the COVID patients. And what we did is that I was trying to check in these patients if this maneuver proposed by Laurent Brochard, they could help us. And the maneuver is something like this. What he's proposing is that you go from a PEEP of 6, you increase to 16, and then you suddenly decrease to 6. You can see here that the respiratory rate was decreased. It's important because to not have any auto-PEEP. This is the only reason why they do this. And then how this maneuver works. The maneuver is something like this. You take this drop, and then you say, oh, look, my PEEP decreased by 10 centimeters. My end expiratory lung volume decreased 1,000 mLs. Okay? But the compliance of the patient was just 30. You calculated the compliance here at some PEEP level. Compliance of the patient was just 30. So if my compliance is 30 and I had 10 centimeters of water change in PEEP, I should, if everything is linear, if compliance is linear all over the PV curve, I should have a drop in end expiratory lung volume of 300 mLs. But I had 1,000, so this drop was 1,000, you see? So then this means that my lung decreased much more than what was predicted by compliance. So then there was some what they call recruitment volume, recruited volume, because you know, you may think the other way around. So I increase my PEEP 10 centimeters of water, I should have an increase in lung volume of just 300, but I got 1,000. So this is because I recruited lots of alveoli. So this is the idea of this method. So then you calculate this recruited volume divided by the expected one, and I have this big number. So this patient is very well recruitable. So this is the recruitment to inflation ratio. A high number means that this recruited volume is much larger than what is predicted by compliance. Okay? But then I think our maneuver is much better. I think it's much more, once you understand the rationale, I think it makes much more sense. And this idea was not mine. This idea came from Bob. So the maneuver is doing the following. So we are, you know, so we just put pressure control, we increase PEEP, and then you go down. But the nice thing is that when you look at the EIT signal, which is a plethysmograph of the EIT, you observe two very nice features. First, this is 10, this is 15 of PEEP, right? So if I compare 15 of PEEP before and 15 of PEEP afterwards, so this is 15 again, I have an increase in end expiratory lung volume, which is precisely what Laurent Brochard is trying to measure, right? So he's trying to measure this gain. But look what happened with the tidal volume. It also increased. And now, I think the nice thing about this maneuver is because now I'm comparing the same PEEP before and afterwards, and then this increase in compliance has to be proportional to the amount of recruitment that you got. This is also proportional, but this is also proportional. And then I think the problem of Laurent Brochard is that he was trying to compare this PEEP with a different PEEP. And then this is not linear because you are not at the same PEEP level. And then you are mixturing, you have a mix of gaining compliance and overdistension. And then it gets complicated. And by doing this, going up and down, you eliminate the overdistension problem. And then the gain in compliance has to be proportional to the gain in recruitment. And this is what we are going to prove now, because we did the CT and EIT analysis. So when the comparison is performed at the same PEEP level, the compliance gain is linearly related to the aeration gain and linearly related to recruitment that you observe in the CT. So if your compliance improves by 30%, very likely you recruited 30% of the units. So you overdistend, and then you go down, nothing happened. So this is a typically non-recruitable patient, very recruitable. So the going down is very different from the going up, and decent recruitment. Okay. So let me jump this. Okay, so then let's see on the Nihon Coden 2. So this is airway pressure. This is compliance. This is a typical non-recruitable patient because compliance went down, went up. So I finish here exactly at the same point. This is a typically non-recruitable patient. And the tool is going to tell me compliance gain, 0. Now compare with this. Airway pressure going up and down. Compliance goes down a little bit and then boom, jumps. This is a very recruitable patient. So the gain in compliance, so here is 10, here is 20. So big gain in compliance at the same PEEP level. So you should always compare at the same PEEP level. So then, wow, this patient is very recruitable. And the EIT, you see this image, green, gain in compliance. Again, in the EIT, you see, I see the same signal that you have in the ventilator. because we are doing almost the same. It's just proximal sensor versus non-proximal sensor, right? Okay, then let me skip this. Now, let's see the results. First of all, gaining compliance. These animals, so we tried to have a model like a viral pneumonia. And every time we tried to do a model that is non-recruitable, I got some injury in the other lung, and then the animal was recruitable. It was very difficult to have a completely non-recruitable model. So I tried to put some plugs in the airways, but then it was sometimes the plug would dislodge. And then we decided to do something a little bit simpler, which is, okay, the recruitable one is the normal animal with some injury. And the non-recruitable was an animal that I had previously recruited and was on ideal PEEP. So then after being in the ideal PEEP, I tried to do a recruitment maneuver on top of this and see if I have any further recruitment. So this was the idea. So then look at this. If the animal was at a 5 of PEEP, very recruitable. So compliance gain calculated by the ventilator, more than 100%. If the animal was previously recruited and I could prove on the CT that all the units were already open, no signal of gain. Then let me just show you this. 1 second. Okay. I like this graph very much. Look at this. Compliance gain at the same PEEP. So this is exactly what the ventilator gives us. One is 100% gain, 40% gain. And this is collapse reversal on the CT. You see all the animals on ideal PEEP are here, and all the other animals are here. And I can see that, for instance, if I have at least 10% more units aerated in the lung, I need to have more than 35%. We can later on play with better thresholds, but I think this is a good threshold to use clinically. So every time you have at least 35% of compliance gain, you have at least 10% more units in the lung. And oh, this is nice. And how much is your reduction in driving pressure? More than 3 centimeters of water.
Yeah, this is, to me,
so
makes more sense. Means more.
Yeah, because.
Abstract.
So So then this is the final result. This is my last slide. So if you have, I like because this is the proof of concept that, okay, if you have a big compliance gain, you are really recruiting anatomically. So more than 10% of units get open. And this represents a reduction of 3 centimeters of water in driving pressure, which is clinically relevant. According to the driving pressure paper, this represents, let's say, each centimeter is 4% lower mortality. So we are decreasing mortality theoretically by 12%. So this is, I think, this is the final result of these two. I think.
So then, Marcelo, should we have that calculation there? Right.
You can. You mean we provide to the physician how many.
Right now, the app says your gain in volume is this.
Forget about gaining volume. Let's present only gaining compliance. I think it's.
Only gain, we don't need the driving pressure reduction.
No. Maybe we can present in this way because you can do this correlation. We can say, oh, you gain 50% of compliance, so potentially you can reduce your driving pressure by X. You can do this calculation. Yeah.
You're using the same peak. You are not doing recruitment and choosing the best peak.
No, no, no. This one I took from the maneuver, not from the PEEP titration. I took from the maneuver.
Okay, okay.